Welcome, everyone, and thank you for joining us today for this on-demand webcast at tctmd.com. Today, we will be talking about a blueprint for bicuspid treatment and TAVR implant strategies for bicuspid patients. I'm very pleased and fortunate today to be joined by two of my esteemed colleagues from around the world. First, we have Basel Ramlawi, who is the System Chief of Cardiothoracic Surgery at Lankenau Heart Institute. And we're also joined by Professor Nicolas Van Mieghem from Erasmus University Medical Center. We're going to be talking today about really a hot topic in interventional cardiology and structural heart disease, which is bicuspid patients, and in particular, low-risk patients with bicuspid aortic stenosis. And I think in the last several years, with data that's come out, the way that we think about these patients has changed a little bit, although I don't know that we have a definitive plan of exactly how we should be treating low-risk bicuspid patients. I hope during the lectures and the talks and the discussions that will be going on today, we'll have a better understanding of what the future holds for these patients and what we should, how we should be treating these patients. With that, I'm going to turn it over to Dr. Ramlawi to talk and to give us some highlights from the recently published Bivolute low-risk bicuspid study.
Well, thank you, John. It's a pleasure to be here with both of you, John and Nicholas, and look forward to a lively discussion looking at our, the next steps for bicuspid valve therapy. So this, in fact, are the results of the bicuspid Bivolute low-risk TAVR trial that were published just recently in last month in JAMA Cardiology. This was a prospective, multi-center, single-arm study to assess the safety and efficacy of TAVR patients with bicuspid aortic valve stenosis who are low risk for surgery. And looking at all the patients, we've included 222 patients that were actually consented into the trial, and we've had 72 exclusions within that study. As you can see, the vast majority of those were really excluded for anatomic criteria, looking at where we thought they were bicuspid, but they were in fact trileaflet valves, and that's about 60 of those patients. 2 patients withdrew. 3 patients themselves, and then 3 patients were withdrawn from the trial by the physician team. And only 1 patient really out of the remaining 7 was excluded for anatomical calcification type reasons. So the vast majority of these patients were allowed into the trial, provided that they met the inclusion and the exclusion criteria at that level there. And one of the key things that we did is we wanted to agree on a unified implant technique for this study, because we wanted all the team members and all the sites to really do this procedure in a similar way so that we can get the best method to assess the efficacy and learn about what is the best way to implant a self-expanding valve in bicuspid valve anatomy. So we agreed that we're going to use an annular sizing strategy, same as trileaflet TAVR, based on the IFU. We agreed also that we are going to predilate all these patients based on the minor axis of the annulus. And we were going to advise for a liberal, controlled pacing strategy, not rapid, but controlled pacing at 120 beats a minute or so. And we'll leave it up to the team to decide whether they want to use a TEE with general anesthesia or a transthoracic, with a target implant depth of somewhere around 2 to 3 millimeters. So not as shallow as some others have advocated, where we definitely don't want this to be in the 0 to 1 range. So somewhere between 2 and 3 millimeter depth, with a confirmation of the implant location in the 80% level within the various views in LAO and RAO, in order to confirm that the location is adequate and confirmed and that we're happy with it, with a TEE and an angiogram with a marker pigtail in the non-coronary cusp, or the lowest point within the aortic valve annulus, prior to removal and confirmation of the deployment process. So clearly, once we have that and the valve has been deployed, we agreed that we would accept anything of a gradient less than 10 and a paravalvular leak of less than mild as an acceptable result. And if it was more than that, whether a gradient or leaking or a paravalvular leak, then that would be, likelihood of post-dilating the valve as needed. So, and what we found, this was a 30-day outcome study, so short-term outcomes. Out of 150 patients and 149 were implanted, The 63%, so just about 2/3, had general anesthesia, and 91%, as recommended, underwent a pre-TAVR balloon dilatation. And of those, only 5 patients, or 3% or so, had more than one valve implanted. But about half, about a third rather, 49 patients, or 32%, utilized the recapturability of the Evolute self-expanding valve and benefited from that aspect in terms of deploying this valve in this bicuspid mortality. So bicuspid valve anatomy, rather. So, and if you look at this, out of the 150 patients or so that were included, we had a 1.3 all-cause mortality or disabling stroke, with 1 death and 1 stroke at 30 days. There were 5 non-disabling strokes, or 3%. And if you look at the permanent pacemaker rates, was just under 15%, or 14.7, which was a little bit less actually than what we saw in the low-risk TAVR study that was published earlier in the New England Journal of Medicine. And of those patients, we had 1 coronary obstruction, which is less than 1% of the total patient population. And one of the things that I'll also leave it at there is I'll conclude with is the outcomes that we had, other than the actual clinical outcomes, were the hemodynamic outcomes, which were quite excellent. So we obviously started off with a higher mean gradient for these bicuspid valve patients. Somewhere around 48 was the mean gradient, and they uniformly all ended up in being single digits with a mean gradient of somewhere around 7 at 30 days. That was sustained up to 30 days or so. And interestingly, that this was also sustained between type 0 and type 1 bicuspids. And we'll talk a little bit more about that with John and Nick in the discussion phase. But really, if you look at this here, that the type 0s did just as well, if not better, than the type 1s, albeit we had smaller numbers in the type 0 patients. But at least there was a trend, and the outcomes were very good, with 84-85% of the patients having no or trace AI, and only 15% having mild with no severe or moderate AI in any of the patient population. So,
Basel, thanks a lot. It's a very short-term result. It's really procedural in 30 days. But when you compare the procedural and 30-day results that were in this bicuspid group, you see it compares very favorably to what we saw in the low-risk tri-leaflet group. I think that's a good thing. I think, one of the interesting things, I want to get Nick's perspective on this, is that, and you brought this up, is that within the study, there was only 1 patient that was excluded for having too much leaflet calcium or too much annular calcification. We know that bicuspid patients often can have a lot of calcification. If you look at the low risk studies, many more patients were excluded in those. And I think that's probably a combination of being a little bit more liberal with who we let in here, now that we've moved from the Evolute valve, which didn't have a wrap, to the Evolute Pro that has the wrap. But I think there's probably also some site selection bias that goes in there. Even though sites were encouraged to enroll everyone, I think we've learned a fair amount about sort of calcification. And maybe it's not whether it's a Sievers 0 or a Sievers 1 valve, but more about the calcification. And Nick, I'm curious your thoughts there as you look at patients and what you're looking at for anatomy.
Yeah. Well, first of all, I'd like to congratulate Basel with a fantastic publication. I think it is quite it's quite an achievement to already publish a prospective study in low risk patients with bicuspid disease. I mean, that demands a lot of courage, but I think you did a great job, and I think the results are fantastic. So I think it was a good choice to proceed in that direction. But I still feel that not all the bicuspid patients have been enrolled in this study, and there was only 1 patient that was excluded because of too much calcium. But of course, the significant number of patients were not within the inclusion-exclusion criteria, right? So that's 60+ of patients, and that, I think, is an important observation, because we all know that bicuspid disease is associated also with aortic aortopathy, and of those patients were specifically excluded from your study, which is important. I think 50% of the younger patients who present with bicuspid disease have some kind of aortopathy that you need to take into consideration as you are discussing during the multidisciplinary heart team. So, so that is one. The other thing is that what I think was striking, it didn't matter so much if it was a Sievers 0 or a Sievers 1, but I agree with John. It's calcium. That's what it's all about. And we'll talk later about some sizing algorithms, but I think a combination of calcified leaflets with a calcified raphe, that's a different animal. So there are several phenotypes within the bicuspid space that make a heart team discussion quite interesting. And still, some patients might do better with surgery, but I think there is a significant group of bicuspids, even low risk patients, who are helped very well with a TAVR solution.
Thanks, Nick. I think maybe we'll move on to the next segment here. So we're going to transition now and talk a little bit about maybe why the Evolute platform should be considered in bicuspid patients. Here's some of my disclosures. So, Basel just showed really nicely that the valve performance of the Evolute valve in bicuspid patients continues to match what we've seen in tri-leaflet patients. And really what that is that we get constant effective orifice areas that are greater than 2 centimeters squared, and we get gradients that are in the single digits. And I think as we've moved from Evolute to Evolute Pro, what we saw is almost the complete elimination of any paravalvular leak that was greater than mild. And the majority of patients, about 60%, having none or trace paravalvular leak, the rest having just mild paravalvular leak, which for the Evolute self-expanding valve hasn't been associated with adverse events. And so the question is, does this make a difference? And I think one of the clear differences between the valves that are out there is that when you have this superannular valve that's self-expanding made of nitinol, actually the shape of the valve at the level of the annulus versus the shape of the valve above the annulus where the leaflet's actually coapt is quite different. We know that in bicuspid patients, annulus can tend to be more elliptical. And the Evolute valve really isn't trying to make those annuluses circular. It's allowing the valve to conform there at the level of the annulus, even at the level of the sinus of Valsalva. And then where the valve itself is located, where the transcatheter leaflets are located, it has a circular shape. I think this impacts in a variety of ways. I think it helps with hemodynamics. I think it helps some with the sealing here. Certainly it decreases the risk of major complications like annular rupture or other things. And the other question is, will it have an impact on long-term durability, having a better hemodynamics, and really having a nice circular form at the superannular level? So maybe I'll get Basel's thoughts here and Nick's thoughts here about, this is certainly a different design. I think there are some things about the design that, be it re-engaging of coronaries, that can make it a little bit more challenging, right? You're going to have to go through the struts here to engage the coronaries, but you're gaining some things with that. So Nick, when you think about that, how do you weigh what you're gaining, a little bit harder to re-engage the coronaries and all that?
I find that a difficult trade-off. I must admit that. But I think now with new techniques like commissural alignment, we also get better in terms of future perspectives to re-access the coronaries. But I do believe that coronary re-access is important in younger patients, as we are dealing with younger patients with longer life expectancy, and 50% of those patients will end up having some kind of coronary disease. But I agree with what you're describing, that this supraannular functioning valve and its circularity is an important aspect. And there is no other way than saying that this is the best in class in terms of hemodynamic performance. I think single-digit gradients and also valve areas above 2 centimeters square, that is just outperforming surgery. And I think this is the only valve, transcatheter valve, that is able to do that. And that might pay dividends in the future, I think.
Basel, you take out a lot of bicuspid valves and you see sort of what the anatomy there looks like. What insights can you give us from a surgeon's perspective?
It's absolutely true what was just mentioned with regards to the volcano shape or the asymmetric aspect of these bicuspid valves, and they tend to actually flare out more, as we all know from looking at many of these CT scans, at the level of the LVOT. So the volcano shape doesn't just stop at the level of the annulus; it actually ends up being even bigger at the level of the LVOT. So it's important that not just the deployment process that we outlined, be done carefully. I completely agree that this self-expanding platform allows for that anchoring to happen at the most calcified portion of the asymmetric portion of the valve, where it simply isn't a circular option, and then still have a fully functional valve at the supraannular level. And that's exactly what we do. Surgically, once you cut it out, it's never a full circle after that.
So Basel, you talked a little bit about this, and I'll turn it over to Nick in a moment. I think one of the other questions is, does Sievers make a difference for TAVR outcome? And I'll be the first to admit that when I was first seeing these patients and seeing them in our multidisciplinary approach, our bias when we were seeing patients was to say, you know what, for Sievers type 0, I think maybe that patient should be going for surgery, whereas Sievers type 1, maybe that patient may be a better TAVR candidate. When we look at the low risk bicuspid study, about 10% of the patients were type 0. That matches about our breakdown here in the United States. The vast majority of those patients were a left-right fusion. The coronaries in these patients can be in a variety of places, especially when it's a type 0 valve. But for these patients who were a left-right fusion, or for the patients who were a type 0 valve, we really saw that, as Basel referred to, that the patients did really well in both instances. And in fact, I think what was remarkable was that while there was no moderate or severe paravalvular leak in any of the patients, about 80% of patients who had a type 0 had absolutely no paravalvular leak, higher than what we saw in type 1. So I think it can give us some insight there that certainly with this self-expanding platform, it's not the type 0, type 1 that we need to worry about, probably more things related to calcification and other anatomic factors, and we need to look beyond the Sievers classification. With that, I want to turn it over to Professor Van Mieghem, because I know he's done a lot of work looking at calcification, looking at the size of the annulus, the size of the supraannular areas, and how, are we able to take a next step even beyond this to better understand and maybe even improve our results from what we've got here.
So I think to answer your question, that was basically the design of the Bivolute X trial. This was a prospective study in Europe where we looked into different sizing algorithms. There had been a lot of discussion on optimal sizing. There were a lot of opinions out there. Some were really arguing that in bicuspid disease, you needed to change your sizing algorithm and focus on the supraannular intercommissural level, because that was where most calcium was, and that was also the area where you had the most eccentricity or ellipticity. But there were other people like myself, who were not agreeing with that. I was typically proceeding with a more annular sizing algorithm, the way I was doing for tricuspids. And so we tried to find a balance there in Bivolute X, where 151 patients were prospectively enrolled. And upfront, the operator had to declare whether the sizing was based at the annular level or whether there was commissural sizing involved. And we had more or less a 50-50 split. And this was not anticipated up front. This was not that by design we were looking for 50% of the patients in annular sizing and 50% with supraannular sizing. That was a coincidence, but it strengthened basically our final results, I think. This trial had an independent CT and echo core lab. There was also an independent event adjudication. And then the interesting part was that if we compared annular sizing with commissural sizing on top of the annular sizing, so most of the time then there was a hybrid kind of approach where the operators were looking at the annulus, but definitely also driving on commissural sizing. Well, in terms of valve performance at 30 days, there was no difference between the two sizing algorithms. Also, in terms of the ellipticity index, at the annular level, the valve was elliptic, as you mentioned, but at the supraannular level, there remained some kind of ellipticity, but at least the gradients were remarkable. They were very low, and we also obtained the same valve areas as in the TDT registry with the Evolute system that you published, John, but also what Basel was showing in the prospective study was also in the same line. So consistently very good results in terms of hemodynamic performance. And also to echo your previous remark, there was no difference whether it was in type 0 or type 1 Sievers bicuspid valves. I think if we then zoom in a little bit further on the sizing algorithms, we can go back to the BAVAR registry, where that was a retrospective analysis of over 200 bicuspid patients, where we looked at the anatomy. What kind of anatomy was this bicuspid? And it turned out that the majority of the cases were either tubular or were flaring down from the intercommissural level into the annulus and into the LVOT. But that tells you that if that is the situation, then why would you then base your sizing on the intercommissural diameters or the intercommissural level? So only in 15 to 18% of the cases, sizing 15 to 80% of the cases at the level of the intercommissural, at the commissural level, the size there was a tapering. So basically, at the commissural level, you will have a larger size than annular or LVOT level. And that probably also is the explanation why we did not see a benefit for systematic sizing at the intercommissural level, but really rely on good annular sizing. But definitely, it's always worthwhile to look at what's happening at the commissural level, because sometimes you see their excessive calcium, or you can see their raphes that are really bugging and precluding optimal expansion of the device. So 88% of the patients had either a tubular or a flaring morphology, and only 12% had a taper in this BAVAR study. And I think recent data that was published this year in JACC from a large study of over 1,000 CT scans, including over 1,000 CT scans from led by Raj Makar and his group at Cedars-Sinai. They looked at the impact of a bicuspid phenotype. And this is, I think, what we discussed already in the beginning. It's not necessarily about a Sievers 0 or a Sievers 1, but it's about the presence of calcium. And you look then at the calcium at the level of the leaflets, and if there is a raphe, also whether the raphe is calcified or not. There is a difference in outcome, and this is shown in this particular slide. You see that if you have the combination of the two, a calcified raphe and a lot of calcium in the leaflets, then the results might be not as good as you want. And in particular, they may not be as good as you could expect from surgery. So you can see that here, almost 10% of the patients will end up with more than mild PVL. And I think especially if we move to younger patients and lower risk patients, that should be not acceptable. If you look at the patients who have either calcified leaflets or a calcified raphe, then the incidence of moderate PVL becomes smaller, but still is not negligible. It's still in the 4 to 5% range. But if none of those is present, then basically the results of TAVR in bicuspids with a supraannular functioning valve are really excellent. So those were the slides that I wanted to share with you guys. And I think a lot of new insights in the last couple of, I think 1 or 2 years, based on clinical data from the United States, but also from CT data from Europe.
Thanks a lot, Nick and Basel. I think I'll conclude here by asking you to give your insights about where we are now. We have a good amount of data that's come out of registries. We have not as much data, but some that's come out of prospective studies. We don't have any data that's come out of randomized studies or long-term data around this. And so when we have a patient who's referred to a heart team with bicuspid aortic valve stenosis, I think there are three questions to ask. One, do we have enough data that we should be saying you should just go, we can do TAVR safely? Should we say we don't have enough and we should just be doing surgery in those patients? Do we need a randomized study for this? Or do we have enough data and enough evidence, as Nick has shown here, to say, you know what, there are considerations that need to be made for each of these patients, and it's imperative that you have a heart team that you look at imaging. And if you look at some of these characteristics, the heart team can make a very good determination about which patients are likely to do well with TAVR, and in those patients, we should strongly consider TAVR. Basel, your thoughts there?
Yeah, I think, listen, I mean, I think you outlined it very well, John. And I agree with Nick in that anatomical considerations definitely should play a role. Clearly, a lot of these patients are going to come in with concomitant disease, whether it's aortopathy, like Nick mentioned, or coronary disease, or mitral, or AFib, or things like that would benefit from open surgical intervention. And they'll do great because they're low risk, and they'll, that we can get them in very safely, even through less invasive surgical approaches. But what the trials and the data has shown is that bicuspid TAVR with a self-expanding Evolute valve works and works well. And we have excellent data to support that now, regardless of the risk profile of the patient. So that's really what I took away from all of this information and all of this data, is that we can do TAVR in bicuspid valve patients with an Evolute valve, regardless of the risk. So really it becomes on the team members to offer the best, sort of options for these patients, considering anatomical criteria, obviously, concomitant disease, obviously. And then I think short of those, once you exclude those patients, I think a randomized controlled trial is something that would be very much welcomed by the scientific community. I think there's always room for more good data, and that's what our RCT would offer. So that's where I would be coming from.
Yeah, I like that. I think from a scientific point of view, it's a no-brainer. You would like to have a randomized study comparing surgery to TAVR in low-risk bicuspids, but I don't believe it's a must-have. I think we already have sufficient amount of data that based on the current evidence, and if you apply 3D pre-procedural imaging, then you can make a good argument in favor for TAVR in selected patients. I think patient selection remains very important. We would not necessarily need a randomized trial for that. We can already identify the bicuspid patients who would do very well with a supraannular functioning valve in a bicuspid in a bicuspid disease. The question is, should we get even better? Should we also modify the pacemaker rates and get even better in PVL? Should we also reduce mild PVL? And I think we're getting there. I think what John already presented from the TVT registry data is that switching from Evolute R to Evolute Pro, just adding this sealing wrap to this design made a big difference. I think just adding that design closed virtually the gap when you compare bicuspid with tricuspids, at least in the patients that were selected within the TVT registry. So John, what would you think about the extrapolation of the registry data to your clinical practice?
Yeah, so I think that combined, that if registry data doesn't match up with clinical trial data, then you need to wonder. But when registry data matches up nicely with clinical trial data, I think it gives it that extra sort of confirmation. I think it's important to note, and I would argue that if a heart team does a thorough assessment and determines that the anatomy is safe and suitable, that's a good thing. I think it's important to note it's not just about the size of the annulus. Nick also mentioned the fact that, you need to look for aortopathies. That's true as well. I want to also highlight the fact that you also have to look at the size of the sinus of Valsalva, and you have to look at the height of the coronary arteries. Patients with bicuspid valves can have coronary arteries that can be exceptionally low, sometimes can have small sinuses of Valsalva. Those patients are excluded here because we know you get a coronary height less than 10 or less than 8, you're going to have a higher rate of coronary obstruction in those cases. And so you really, in these patients, need to be looking at everything. And I think that's the benefit of having these heart teams where there's a surgeon, there's imaging specialists, there's interventional cardiologists. We've come a long way. I think we understand that, but I think it's also important when we're talking with patients, when we're talking with referring cardiologists, et cetera, that they understand this patient, this 65-year-old with a bicuspid may be a good candidate, but we really don't know until we take a very individualized look at that patient's anatomy, what would be really ideal or best for the patient.
I think what I also wanted to add, and what I also take from what Basel presented, was the fact that standardization is very important. I think you stress the importance of pre-dilatation, but also post-dilatation in a significant number of cases. And basically what you were showing was almost copy-paste to what we found in Bivolute X. And this was, we more or less used same standardized protocols for the valve implants. And I think that this becomes so crucial. You cannot have like every center having their own way of implanting these valves. I think you do need some standardization with these cases.
Yeah, completely agree.
With that, I think our 30 minutes is up here. I want to thank Dr. Ramlawi and Dr. Van Mieghem for joining us today. Hopefully, we're all in person soon, and I wish everyone both on this panel and listening here that you and your families are staying safe in these challenging times. And thank you again, everyone, for joining in this opportunity.